Assalamualaikum dear doctors. In this video I am discussing a video stations, and this video station also come on clinical exam. This is very important. So look the image what we are seeing. First image, look, this child is tall, thin, there is a long face, and he has school uniform. He wearing a glass in her eye, in his eye. So school uniform, that means that he is mentally okay. Now the second image, there are two images. The up image is that is showing that is kyphoscoliosis, okay, and the below image is that is high arched palate, look, and the third image, the upper image is showing that is pectus excavatum, and the below that is showing arachnodactyly. Now we are telling how we can do this video station. So describe this picture. We are seeing that is tall stature, kyphoscoliosis, pectus excavatum, high arched palate, and arachnodactyly. All features are going for Marfan syndrome. What are the other features of Marfan syndrome? That is, arm span is more than the height, lower segment is more than the upper segment. There is Sternberg sign that can adduct the thumb across the palm. CVS, we find mitral valve prolapse. Aortic dissection and check blood pressure. Respiratory system, we find the pneumothorax. Eye, we find lens dislocation upward and out. Now, what are the differential diagnoses of the tall stature? That is homocystinuria. Remember, Marfan syndrome cousin is homocystinuria, but homocystinuria, the child is mentally retarded. So the DDR homocystinuria, Sotos syndrome, Beckwith-Whiteman syndrome, Klinefelter syndrome, acromegaly, Klinefelter syndrome, hyperthyroidism, and familial tall stature. Now, what investigation we do for this Marfan syndrome patient? First, echocardiography. What we do? Repeated annually with careful monitoring of aortic root width, and the function of the heart valve is recommended. Echocardiography is also being used to evaluate the function of the myocardium, which is also thought to be affected. Then cardiovascular magnetic resonance, CMR, or computerized tomography, CT, should be performed in every patient, showing the entire aorta. This should be repeated every 5 years or annually if there is aneurysmal formation beyond the aortic root. Now, ambulatory ECG monitoring in symptomatic patients. MRI scanning of the spinal column. Consider this is headache or sacral pain is potentially attributable to dural ectasia. Pelvic X-ray. This may demonstrate the protrusion of the acetabulum into the pelvic cavity. Protrude acetabula. It is present in about 50% of cases. So the investigation for Marfan syndrome, we do the echocardiography, CMR, CT scan, ECG, X-ray, and MRI. And aortic root dilatation we find in echocardiography. This is important. For the diagnosis and management. Diagnosis is based on clinical features, genetic testing. Management. Management requires a multidisciplinary team which should include a geneticist, an ophthalmologist, a cardiologist, and an orthopedic surgeon. Non-drug treatment are psychological support, avoid exertion at maximal capacity, vigorously competitive or contact sports. Drugs we give the prophylactic beta blockers are used to reduce the mean arterial pressure and pulse rate significantly. Surgical treatment we give the with progressive aortic disease, dilatation of the ascending aorta and valve ring, composite valve or aortic root graft replacement. So this is all about the Marfan syndrome video station. Please do subscribe and share MRCPCH with Dr. Amma Choudhury. Thank you.